And today we have Dr. Sanjay here, and who is currently working at Nasik, and is DM from Mumbai, and is worked in the Australia and UK also, and Canada, all
Yes.
three places. And he is going to talk about the most relevant aspect, which later you realize. Once you start ventilating, you have ventilated many babies, then you realize, there is a lot of problem in weaning, especially the smaller babies. Lot of problem in the weaning, and also weaning of babies with diaphragmatic hernia, and also weaning the baby with severe MAS, term babies. Many of the term babies has got severe MAS and very high, the ventilator with high frequency ventilator, their lung also get damaged. Then also we have problem in the weaning. And weaning and lung injury, go hand in hand. If you have lung is injured, weaning is difficult. So Sanjay is going to talk on this. And Sanjay, here you can start.
Yeah. So good evening, everyone. So first I'm going to talk about weaning and extubation, and the second talk will be on ventilation-induced lung injury. So as now we were discussing that we are catering many of the VLBW and ELBW. And if you see these babies, around 89% of ELBW babies need mechanical ventilation in early days of their life. And out of these 89%, 95% of neonates, those who survived, had a history of invasive ventilation during hospitalization. In another core study, they reported 74% of the neonates born before 28 weeks were intubated and received surfactant during hospitalization. So because more of the low birth weight and premature babies are surviving, and mechanical ventilation is the integral part of their management. And it is not without complication. We all know that mechanical ventilation can injure the lungs. And the first thing is ventilator-induced lung injury, where we have barotrauma, volume trauma, electrotrauma, and biotrauma. Then they are also susceptible to various infections and especially ventilation-associated pneumonias. Then injury to trachea, to the epiglottis, to the gums, sometimes to the lips during the intubation. So various injuries can happen. And if something goes wrong during the intubation process and baby suffers from hypoxia, it can have neurodevelopmental impairments in the future. That's why now it is recommended that the treating neonatologist should wean a premature neonate from mechanical ventilation as soon as possible. So what is the evidence? We have lots of evidence in adults. About 20 years ago, American College of Chest Physicians recommended a protocol for weaning adult patients from respiratory support machines. These guidelines were prepared according to the randomized controlled trials. Those showed improved outcomes for adults managed using these protocols. However, it is inappropriate to apply these adult data to term and preterm neonates. So in 2011, a systematic review showed that using protocols for weaning neonates from ventilation reduced the length of hospital stay and length of time on the mechanical ventilation. Another review published in 2020 found that weaning protocols in neonates were used in very small percentage of patients and had contradictory results. So we don't have universal protocols to be followed in every NICU. So every NICU have their own protocol. In general, these studies have supported need for protocol, and more RCTs are required to evaluate the effect on preterm neonates. There are several mechanical ventilation strategies, and you have heard various speakers over the last 1 week about these various ventilation strategies. Auto-weaning from invasive ventilation makes it challenging to formulate a universal protocol that will serve all patients and providers. So this topic has already been covered by a previous speaker. So we can use these various ventilation modes and strategies like pressure targeted ventilation, assist control ventilation, SIMV mode, volume targeted or volume guarantee mode, and high frequency ventilation. So I'm not going to discuss these various modes. We'll jump to the how to assess a baby for extubation readiness. So what is the definition of extubation failure? So it is defined as a need for reintubation in first 48 hours to 7 days after extubation, and it is reported to be very high as 10 to 80%. Different tools such as estimators and machine learning approaches have been used to evaluate extubation readiness in neonates. Meticulous serial evaluations of readiness for extubation are essential in weaning neonates from ventilation, but early extubation may be associated with respiratory failure, reintubation, and sometimes very tragic complications can happen with early extubation in extremely low birth weight babies. So what are the parameters to predict extubation? So there should be sufficient neuronal signs and neuromuscular synapses, functional capacity of the respiratory muscle, and primary pathology of the lung. So these three things will decide success of extubation. So once an adequate gas exchange is achieved with low peak and FiO2 in a hemodynamically stable neonate, and the respiratory drive shifts towards spontaneous breathing, the neonate is ready to discontinue invasive ventilation and extubation. So in clinically, there is a recent post study which shows extubation neonates successfully when their weight was good, they were more mature, and they required less oxygen within first 24 hours of birth and before extubation than the failed cases. So this is very important, the weight of the baby, the maturity, and requirement of the FiO2 during first 24 hours. Moreover, the successful extubation group had lower carbon dioxide levels, lower mean airway pressure, and high pH, or there was no acidosis in these babies before extubation. Another tool is used in experimental studies called as a tension time index. So in the study of 20 neonates born between 24 to 39 weeks receiving mechanical ventilation, they found the TTI of diaphragm and the respiratory muscles predicted extubation success with high sensitivity and specificity. And the results also showed diaphragmatic dysfunction in neonates with extubation failure. However, subsequent studies showed that this TTI is less sensitive than the gestational age and the birth weight in predicting extubation readiness, and its use was not recommended in clinical practice. So what should be the minimal ventilator settings before extubation? In an Apex code study, neonates were extubated from different settings and parameters, including the map between 5 to 14 centimeters of water, FiO2 requirement between room air to 53%, and PCO2 levels between 22 to 69. So no significant difference was observed in success of extubation. So overall, there is no definite evidence for determining an optimal time for extubation. Another tool is used called as a spontaneous breathing trial. So in this, around 30 to 120 minutes for assessing readiness for extubation have proved effective in adults and are evidence-based. Neonates who underwent this spontaneous breathing trial were extubated faster than those only assessed clinically. This SPT has a very high sensitivity and positive predictive value, but low specificity and negative predictive value in evaluating readiness for extubation. So despite its low cost and availability, the spontaneous breathing test cannot be considered a test with accurate results in assessing neonates' readiness for extubation. And various trials are published from 2017 to 2021. Other techniques such as measuring the minute ventilation on CPAP for 10 minutes, comparing it to the minute ventilation on mechanical ventilation before CPAP trial have reported a very increased extubation success. Then autonomic nervous system function, lack of heart rate variability in preterm neonate has been associated with sepsis and very worse clinical outcomes. So in one study, 47 preterm neonates between 1250 gram, under 1250 gram, they found markedly low HRV, that is heart rate variability in neonates that experienced extubation failure. This test is very specific and positive predictive value is close to 100%. There are various newer techniques and indices like respiratory variability index, automated tools that analyze MATLAB compliant, machine learning, and automated RVI and HRV assessment methods. This tool can reduce extubation failure from 20% to less than 5%. And what should be the checklist when you are going to extubate a baby? So one author has proposed this checklist. Sureta published a review that provided a checklist of criteria that a neonate should meet 24 hours before extubation. So at the beginning of the shift, the physician should inform the coordinator of the potential for extubation. Then steps may be taken, such as implementing a trial on CPAP, stopping the baby's feed, then spontaneous breathing trial optional, changing to pressure support 2 hours before planned extubation. So all these steps can be taken before you plan the extubation. Then continuous distending pressure devices such as CPAP or NIPPV can be rated 1 hour before extubation. Then nursing care and observation of the neonate for signs of increased work of breathing are performed 30 minutes before extubation. And finally, the neonate is extubated. So these protocols may reduce the stressful experience during extubation and reintubation, but there are no generally accepted guidelines for the checklist. But this is just an idea of what we can do before we plan extubation in preterm babies. And this is published in 2022. So there are various quality improvement studies being published about success of extubations. So in one study, they performed a quality improved intervention to reduce unexpected extubation in neonates. So after implementing the QI intervention, there was significant decrease, around 80% in unexpected extubation rates. Another study in 2018, the intubation following extubation decreased from 41.7% to 23.8%. Then what is the post-extubation management? So there is inadequate respiratory drive and muscle strength to maintain the functional residual capacity. The vocal cords may become edematous during intubation, so preventing effective grunting in these babies. And they need continuous distending pressure either by CPAP, by NIPPV, or by humidified high flow nasal cannula. The use of CPAP. So it is necessary to provide continuous distending pressure immediate post-extubation in premature infants. Not necessary for term babies, but in preterm babies, especially below 28 weeks, we need some device to maintain the continuous distending pressure. Different types of CPAPs and other modalities like NIPPV or high flow nasal cannula is also used. So high flow nasal cannula was previously believed that the pharyngeal pressure generated by this is low and unstable and cannot create the required CDP. And evidence has shown that failure following extubation with HFNC is more significant than the traditional nasal CPAP. And it is also associated with more apnea, bradycardia, increased work of breathing after extubation with high flow nasal cannula. But a recent systematic review, 33 studies and 4,000 neonates found that the effect of high flow was similar to nasal CPAP, and it was safest and the most comfortable non-invasive modality for post-extubation with minimal nasal trauma and early compared to other methods. So it is not inferior to CPAP and other modalities, especially for post-extubation, not as a primary mode of ventilator support. Then we were just discussing about the use of NIPPV, and now it has become more popular as compared to CPAP. So in 2017, a Cochrane review of 10 clinical trials comparing CPAP versus NIPPV showed that NIPPV effectively reduced extubation failure and intubation, but had no effect on the incidence of chronic lung disease and mortality. In this NIPPV, synchronized NIPPV was more effective than non-synchronized NIPPV. Then is there any role of pervasive hypercapnia? So several studies defined pH, pervasive hypercapnia as CO2 levels between 45 to 65 millimeters of mercury, as long as your pH is maintained above 7.20. Pervasive hypercapnia is the safest strategy to prevent ventilator-induced lung injury. And preterm neonates exposed to hypercapnia have a better respiratory drive, and studies have shown fewer days of invasive ventilation and lower rates of BPD. Then we all know the role of caffeine. So this is very popular trial, CAP trial. In this trial, extubation was earlier in 33% of the cases, and post-extubation apnea was reduced by 20% in caffeine group. And neonates who received caffeine had shorter lengths of time on mechanical ventilation, CPAP, oxygen therapy, and also they had lower rates of BPD. Another systematic review published in 2019 found that using a higher maintenance dose of caffeine was associated with low mortality and BPD rates. And is there any role of postnatal corticosteroids? Treatment with low-dose hydrocortisone in first 2 weeks of life increased BPD-free survival, especially in neonates born with prenatal inflammation. And studies show that high-dose dexamethasone, that is 0.5 mg per kg per day, reduced the prevalence of BPD, but was associated with severe short-term and long-term neurodevelopmental abnormalities. Then recently, treatment with low-dose hydrocortisone, 1 mg per kg per day in first 2 weeks of life improved BPD-free survival, especially in neonates born with prenatal inflammation without an increase in neurodevelopmental delays. 21 RCTs of postnatal corticosteroid use analyzed in a review article showed an unfavorable risk-benefit ratio in neonates with mild disease. So in contrast, the outcome of late corticosteroid administration was favorable for cases where the baby cannot be weaned from mechanical ventilation. So administration of postnatal corticosteroid after first week effectively facilitated extubation and reduced BPD. Several short-term difficulties, including GI bleeding, intestinal perforation, hyperglycemia, hypertension, cardiomyopathy, and short-term growth disorders were seen in these babies, and long-term complications such as neurodevelopmental disorders and cerebral palsy were more common. Then about post-extubation stridor. So in 2008, a Cochrane review showed that steroids had no confirmed role in prevention or treatment of post-extubation stridor in neonates and children. And further evaluation revealed that steroids were an acceptable treatment in post-extubation stridor. So steroid, even at a lower dose, can be effective in weaning process. Risk-benefit assessment should be done, and the physician should use clinical judgment to maintain balance between positive effects on lowering the incidence of BPD and the side effects in each patient. So if steroid is necessary, it should be prescribed for a short time, and the risk and benefit should be discussed with the parents. So it is very, very important. If a baby is stuck on a ventilator and you want to give a long period of steroid, then you have to take a consent from the parents. Then is there any role of diuretics? So we know the effect of diuretics on the length of ventilator support and oxygen supplementation and hospital stay. The possible benefit of this drug should be weighed against their known side effects before making routine use. Then chest physiotherapy. It is hypothesized that chest physiotherapy, including percussion and vibration before and after extubation, may facilitate removal of the secretions and improve pulmonary function. In 2010, a Cochrane review showed that chest physiotherapy had no effect on reducing pulmonary secretions and may effectively prevent atelectasis, but the available data are not conclusive about chest physiotherapy. Then we all know the role of nutritional support in extubation. So it is logical that neonates should be provided with aggressive nutritional support during their early neonatal period during intubation to prepare them for the post-extubation phase. So what is extubation failure? Extubation failure is defined as need for intubation after extubation within predefined time, depending on the healthcare center criteria, and that usually ranges between 2 to 7 days. After 7 days, reintubation is usually secondary to other pathologies unrelated to neonate's condition immediately after extubation. So mainly it should be between 2 to 7 days post-extubation. And the prevalence is between 10 to 80%. So what are the different factors for extubation failure? So first and the most important is the prematurity and respiratory muscle weakness. Then if the baby has other airway abnormalities, the baby has hemodynamically significant PDA, poor respiratory control, injury to the lung, nosocomial infection, and ventilator-associated pneumonias. Various risk factors like low gestational age, babies below 26 weeks of gestation, then receiving ventilation for more than 2 weeks, acidosis, higher PaCO2 before extubation, and if you extubate a baby from high settings and low SpO2 or FiO2 ratio increase the risk of failure. And if baby has inconsistent respiratory drive, if they have poor respiratory from upper airway Malaysia, like tracheomalacia, these babies may fail extubation. Then alveolar atelectasis, hemodynamic instability, PDA already mentioned. Then glottic and subglottic edema can also have failure, and residual lung injuries such as BPD. There are certain NICU factors. If the person who is taking care is not adequately trained, non-availability of the respiratory therapist during the extubation phase and post-extubation phase, inadequate training of the residents, early extubation, especially in ELBW babies, they are going to fail. Then lack of a protocol for initiation and termination of the ventilation. Then if you are using sedatives or relaxant, muscle relaxant, then that baby is going to fail on the extubation. Then delay in obtaining chest radiographs or arterial blood gases. If the facilities are not available, then again it is a problem. And lack of proper post-extubation CPAP after extubation. So these are various NICU factors. So intubation increases the time of exposure to mechanical ventilation by 10 to 12 days, which was associated with both short-term as well as long-term complications. So what are the complications? So endotracheal tube malposition, trauma to the nose, clotting, trachea, and the lungs. Then airway collapse. This is commonly seen, right upper roof collapse. Then asphyxia, the baby becomes hypoxic, and increased risk of infection with the multiple attempts of intubation. So there should be a single definition of extubation and the rate of extubation failure, and respiratory and non-respiratory causes of each intubation should be determined. And severe post-extubation complications should be closely monitored and documented during the first 24 hours, including hemodynamic instability, severe or prolonged hypoxia, and severe IVH and death. So how you can do it with cost effectiveness? So Sharma et al. Reviewed the cost of NICU stay published in various older studies. They found that the cost varies based on the neonate's gestational age, level of care, degree of illness, and it varies between $90 to 1,250 to 2,500 US dollar per day. The cost of NICU can be reduced with several interventions, including preventive invasive mechanical ventilation with widespread of CPAP. So regarding cost effectiveness, CPAP reduces costs compared to NIPPV and mechanical ventilation because it is quite cheap to administer CPAP as compared to NIPPV and mechanical ventilation. So these are the simple guidelines for extubation. So initially you decrease the FiO2 to 30%, while your SpO2 is maintained between 91 to 95%. Then based on the carbon dioxide level, reduce the tidal volume and the rate of the ventilator. With improving oxygenation, it can be decreased. Caffeine is loaded, especially in very low birth weight preterm infants, and all sedatives are discontinued before you plan extubation. Before weaning, baby may be placed on CPAP for 3 to 10 minutes. And if there is no discomfort or increased work of breathing, the neonate is extubated and NIPPV or CPAP is administered post-extubation. Extensive use of NIPPV after extubation helps early weaning, resulting in higher MAP than CPAP or high flow nasal cannula alone. And if you use higher PIP on NIPPV, then extubation failure is very less. Other techniques such as maintaining hand hygiene, preventing overcrowding in the NICU, and using the protocols to reduce infection rate and aggressive nutritional support is very, very important in success of extubation in extremely low birth weight babies. So that was regarding weaning and extubation for neonates on mechanical ventilation. Shall we take the questions before we move to the next topic, or we'll finish the presentation?
You can finish it.
Finish it?
Yeah.
1 second. Slides are visible?
Yes, yes.
So in this talk, I'm going to discuss about VILI, that is ventilation-induced lung injury in neonates, and what is the evidence for this, and what are the lung protective strategies. So as I already discussed that extremely low birth weight babies need mechanical ventilation during their NICU stay, and mechanical ventilation by itself may inflict and accentuate lung injury. So this secondary lung damage caused by mechanical ventilation, it is called as a ventilator-induced lung injury. And it is very, very important risk factor in PLPW to develop bronchopulmonary dysplasia. Up to 95% of surviving LBW infants will be exposed to mechanical ventilation during their stay in the NICU, and 30 to 80% of them require mechanical ventilation during first few days of life. So what is the pathology? So acute lung injury caused by mechanical ventilation is characterized by inflammation and diffuse alveolar damage. So that is the basis of lung injury, inflammation and alveolar damage. And histologically, there are 3 pages. The first is acute or exudative phase. Second is organizing or proliferative phase, and the late resolving or fibrotic phase. So during the acute phase, there is edema, then alveolar hemorrhage, hyaline membrane formation, and interstitial widening. This type 2 pneumocyte hyperplasia occurs towards the end of this acute phase. In late resolving phase, the granulation tissue incorporates into the septa, accompanied by fibrosis and hyalinization of the alveolar walls. So chronic severe VD in neonates is characterized by inflammation, airway epithelial metaplasia, smooth muscle hypertrophy, and parenchyma fibrosis. In post-surfactant era, so this was pre-surfactant, so there was muscle hypertrophy and parenchymal fibrosis. In the post-surfactant era, the neonatal lung injury is mostly mild to moderate. It is characterized by limited lung fibrosis and basically arrested alveolar and pulmonary vascular development. So that is the difference between old BPD and new BPD. What are the various risk factors and pathogenesis? So first and most important is the mechanical ventilation. The pathogenesis is multifactorial and complex, and these are the various factors like volume trauma, barotrauma, atelectrauma, oxygen toxicity, and biotrauma. There are certain patient-related factors like extremely low birth weight babies with immature lungs, surfactant deficiency, asymmetric lung disease in these premature babies, and inflammation or congenital pneumonia in these babies. So let's discuss about ventilator-related risk factors. So you can see this video. So you can notice, so there is complete collapse of the alveoli, and with the ventilation, there is lungs are inflated. So there is atelectasis at the end of the ventilation. Here you can see very well opened alveoli and uniformity in the ventilation in this type of ventilation. Here you can see some alveoli are hyperinflated, some are atelectatic. So this is what happens in the lung injury. So let's discuss about volume trauma. So when the lung is exposed to high tidal volume, it causes volume trauma. So overinflation of the lung will cause overstretching of the airway and alveoli, resulting in the edema, increased protein sieving in the pulmonary microcirculation. And it is associated with the release of proteases, cytokines, chemokines, leading to activation of macrophages and neutrophils and increased inflammation and injury in the lung. It also decreases the response to surfactant treatment. Sometimes we give second dose of surfactant, but still it doesn't improve. So it may be because of volume trauma. What is the clinical evidence? So in this study, they reported that volume targeted ventilation or volume guarantee stabilizes the delivered tidal volume during mechanical ventilation in preterm infants. Another study demonstrated that volume targeted ventilation could reduce pulmonary inflammation in preterm with respiratory distress syndrome. The benefit of controlling tidal volume and limiting volume trauma have been noted in randomized controlled trials that compared volume targeted ventilation to pressure limited ventilation. And a meta-analysis of this study show that volume targeted ventilation compared to pressure limited ventilation, it significantly reduced the combined outcome of death and BPD at 36 weeks post-menstrual age. Another recent review emphasizes that avoiding volume trauma may be important not only in decreasing the lung injury, but also brain injury in units. So that is the importance of using volume targeted ventilation or volume guarantee to reduce volume trauma. And the next factor is barotrauma. It is overstretching of the airways and alveoli from exposure to extreme positive pressure. Severity of lung injury was directly proportional to the administered peak airway pressure in these babies. So what is more injurious, pressure or volume? Various studies have demonstrated that more than the higher pressure per se, it is the degree of lung overinflation that determines the lung injury. So volley trauma is more dangerous than the barrel trauma. So the next one is atelectotrauma. It results when the ventilation with low lung volume. So if you are not delivering adequate volume, so baby's alveoli will be atelectatic. This type of injury results from shear pressure secondary to repeated alveolar collapse and expansion. We saw that one video where the alveoli were opening and closing without use of heat. So very preterm infants are at high risk of arrest because they have difficulty maintaining their upper airway patency and functional residual capacity. It also causes surfactant dysfunction. So positive pressure ventilation with inadequate peak leads to low residual volume and inability to establish functional residual capacity and atelectasis. So that is the main reason, inadequate peak while ventilating a baby. Then next comes the oxidative stress. So we all know excessive oxygen or hyperoxia causes injury to the lung. And in one study, Norway initially described BPD as a disorder resulting from the lung oxygen toxicity. Preterm infants are particularly susceptible to oxygen toxicity because the antioxidant mechanisms are not fully developed until the third trimester. So in a single randomized control trial, in infants born between 24 to 28 weeks, compared higher, that is 90% versus lower, that is 30% initial oxygen concentration in DR. Infants who received a higher oxygen load had a higher oxidative stress and inflammation and were at high risk of developing bronchopulmonary dysplasia. So that's why we have new NRP guidelines where we don't use high starting FiO2 while resuscitating preterm babies. Similar results were reported in infants between 24 to 34 weeks who were randomized to receive either room air or 100%, and they titrated to achieve SpO2 target between 85 to 94%. So oxidative stress, respiratory morbidity, and BPD rates were lower in infants initially resuscitated with room air. The mortality and necrotizing enterocolitis was increased, and severe ROP was reduced in low oxygen saturation targeted infants. The next is biotrauma. It results from release of inflammatory mediators like cytokines or chemokines secondary to injuries caused by all these volume trauma, barotrauma, atelectotrauma, and oxygen toxicity and sepsis. Biotrauma can cause systemic infection or sepsis when the respiratory tract is infected or colonized with pathogenic organisms. So the risk of ventilator-induced lung injury is directly proportional to the duration and amount of energy delivered to the lung. And mechanical power is functional of tidal volume, respiratory rate, and PWP. So use of higher mechanical power was associated with increased risk of bronchopulmonary dysplasia. Next comes patient-related risk factors. So we saw the ventilator-related risk factors. Now the patient-related risk factors. So immaturity of the lung. So preterm infants are susceptible to lung injury because their lungs are structurally and functionally not matured, and they are not equipped with repair mechanisms to counter adverse effects of these supportive therapies. If there is a pre-existing lung disease, so if you see this diagram, so the pre-existing lung disease, especially asymmetric lung disease, is a significant risk factor for ventilator-induced lung injury. And heterogeneous tidal volume is distributed leads to regional volume trauma of the healthy lungs, despite the administration of normal range in the baby. So here you can see, so this is the normal lung. Every alveoli is getting same volume, but Then there is atelectatic alveoli and normal alveoli. So the normal alveoli will get over distended and will cause more damage to the normal lung. The next factor is nutrition. So optimal nutrition is very, very necessary for development of the lung and repair. And preterm infants are at risk of poor nutritional state due to the increased work of breathing. Their intestinal tract is not mature. They are on restricted fluids and they are also exposed to various medications like steroids and diuretics. So the role of nutrition is very, very important. So immune studies suggest that increased caloric intake in first days of life is associated with decreased respiratory morbidities in preterm infants. So why we are worried about VILI? What are the consequences of ventilator-induced lung injury? So if we compare to a normal alveoli, in a damaged lung, you can see loss of epithelial and endothelial cell barrier integrity. Then there is activation and recruitment of inflammatory cells. Then it causes lung inflammation and edema. Then it also causes surfactant dysfunction and ventilation perfusion mismatch. It can lead to system organ failure, then bacterial translocation and sepsis, and lastly bronchopulmonary dysplasia. That's why we are worried about VILI. So various lung protective strategies can be used to prevent ventilator-induced lung injury. So various strategies like open lung ventilation, preventing volume trauma, the role of high-frequency ventilation, then preventing and reversing atelect trauma, and non-invasive respiratory support. So first, open lung ventilation strategy. So avoiding excessive tidal volume and facilitating uniform distribution of this tidal volume and decreasing volume trauma and atelect trauma is the key for prevention of acute and chronic lung injury. So decreasing alveolar over-distension by targeting tidal volume attenuates VILI. So tidal volume is better regulated and stabilized by volume targeted ventilation than pressure limited ventilation. In a Cochrane review recently, RCTs comprising more than 1,000 infants reported that volume targeted ventilation reduced primary outcome of death or BPD at 36 weeks PMA and the secondary outcome of pneumothorax, duration of ventilation, incidence of hypocarbia, severe IVH and periventricular defibrillation was significantly reduced in those babies who received volume targeted ventilation. Then lung protective strategies with conventional ventilation may be as good as HPV in preterm infants. The studies have shown that we can ventilate equally, not on high frequency, but with lung protective strategies on conventional is as good as using high frequency ventilation. And how we can prevent or reverse atelect trauma. So CPAP or PWP can improve respiratory function by reducing upper airway resistance by splinting the airways. It increases functional residual capacity. It reduces inspiratory resistance by dilating the airways. It increases compliance, stabilizes the chest wall. It increases the mean airway pressure and improves the ventilation perfusion mismatch. And it also conserves surfactant. Then non-invasive respiratory support. So there are 3 landmark studies which compared CPAP to mechanical ventilation: COIN trial, support trial, and Vermont-Oxford network trial. So COIN trial was published in 2008. 610 infants between 25 to 28 weeks. Initial respiratory management with either CPAP or mechanical ventilation. And CPAP decreased the days on mechanical ventilation and requirement for oxygen at 28 days. They did not find any significant difference in the rates of death or BPD between the groups. The support trial was published in 2010. They enrolled 1,300 infants between 24 to 27 weeks and randomized them either to initial CPAP therapy with subsequent selective rescue surfactant or to primary mechanical ventilation with prophylactic surfactant therapy. There was no significant difference in the rate of death or BPD between the groups. However, the infants randomized to CPAP treatment required less frequent intubation, fewer days on mechanical ventilation, and decreased postnatal corticosteroid therapy as compared to those who were primarily ventilated and prophylactically surfactant was given. The third one is Vermont-Oxford network trial. So they randomized 648 infants between 26 to 29 weeks, published in again 2011. So they randomized to prophylactic surfactant followed by mechanical ventilation, prophylactic surfactant followed by extubation to CPAP, or initial CPAP with selective surfactant drip. So there are three arms. The rate of death or BPD at 36 weeks PMA between the groups were not different, although early CPAP reduced the need for intubation and surfactant treatment. And we have a meta-analysis comprising all these studies. So early surfactant administration with brief mechanical ventilation followed by extubation to CPAP versus selective surfactant administration followed by mechanical ventilation extubation from low respiratory support showed that the former treatment. So this is surfactant comprising early surfactant with brief mechanical ventilation is superior to selective surfactant followed by mechanical ventilation. So Committee on Fetus and Newborn by the American Academy of Pediatrics, they came up with a policy statement. So early use of CPAP with subsequent selective surfactant administration in preterm infants results in low rates of BPD or death compared to prophylactic or early surfactant therapy. And what is the evidence for NIPPV versus CPAP? So NIPPV was associated with reduced incidence of combined outcome of BPD and death compared to CPAP. A meta-analysis of 3 studies, including 360 infants, concluded that NIPPV was superior to CPAP in preventing invasive ventilation. A recent meta-analysis indicated that when compared to CPAP, ventilator-generated synchronized NIPPV may decrease BPD incidence in preterm infants. So we have to summarize, mechanical ventilation is the key risk factor for both acute and chronic lung injury. And the emphasis should be to avoid mechanical ventilation and use non-invasive respiratory support, if possible, as the initial modality to manage RDS in ELBW infants. The fundamental principle is to achieve acceptable but not entirely normal level of gas exchange with least deleterious form of ventilatory support. End inspiratory alveolar over-distension should be minimized by employing volume-targeted ventilation. And the functional residual capacity should be optimized by reversing atelectasis and stabilizing the lung units by providing sufficient PEEP or CPAP. Again, same thing here. So minimize end inspiratory alveolar over-distension, so decrease volume trauma. Optimize FRC by reversing atelectasis and stabilize the lung unit through prevent atelic trauma. So optimal lung volume or open lung ventilation strategy is best. And optimal tidal volume throughout the lung by using volume targeted ventilation. And this will improve the oxygenation and decrease the FR2 requirement and less oxygen toxicity. So that's regarding the video, ventilation-induced lung injury.
Delegates, if you want to ask anything, any question, you can put in the chat box.
Dr. Rajesh, you can tell your experience. You were saying in the beginning